All right, hello everyone. It's Brian Tuckey here, the developer of Fascial Counterstrain. As you guys, I'm sure, are aware, there has been a break in the Jones Institute schedule due to the COVID situation. So the Jones Institute and I were trying to find a way that we can continue to improve everyone's skill set and knowledge base despite the fact that we can't get together to train. So Kyle contacted me and he said, Brian, do you have any content that would be appropriate for a webinar that we could offer as a free webinar to everyone, again, to keep you guys progressing your skills and your knowledge base. It's also kind of an ideal time to learn something new because everyone's caseload is cut in half or worse. You may just be quarantined at home with your family. So I said, yeah, Kyle, the progression recently of the ability to use the fascial counterstrain method in the area of scar tissue has become extremely powerful, and it's now something I do in almost every single patient. The history of scar tissue fascial counterstrain is long. Many of us have treated contracted scars on the surface via incisions for many years. You'll see a patient come in, for example, that has 4 orthopedic scope holes on their postoperative knee, and you'll see that 3 of them are not edematous, 3 of them move wonderfully, and yet there's 1 scar that is swollen. It's slightly red, and it's tender to the touch. And if you go ahead and try and break that up with a standard scar tissue treatment, you'll see that it doesn't work well, and it basically just causes pain. So for years, if you take that adhered scar, swollen scope hole, and you check it in 3 dimensions, go proximal distal, find your direction of ease, medial lateral, find your direction of ease, and then maintain it in that position, you will feel drainage, therapeutic pulse, and that scar literally becomes a mobile scar. It's treatment of the superficial fascial system, it's treatment of the patellar retinaculum beneath that, but it's always worked, and it allows us to treat a non-standard tender point using the fascial counterstrain method. So, like many concepts, this concept started to progress over the years. And about 6 months ago, I started really in earnest doing the same concept and trying to identify internal scar tissue. So patients who had hysterectomies, C-sections, or painful and damaging birth process, for example. You may have a woman with persistent sacral pain, and I would feel tension, tenderness along the sacral border, but no scan to indicate that existed. So I would go ahead and go into the area of the bladder and the uterus, and I would, in 3 dimensions, do that stacking direction of ease, but feel the change on the sacrum posteriorly. So basically using the same philosophy for internal scar tissue in a 3-dimensional stacking. And again, it really worked well, and it kind of progressed the whole thing to another level. I started to identify this in patients who had pleural scarring, who might have gone through a chest surgery or had a history of bronchitis or pneumonia, and it really was something that was much more prevalent in the body than I initially realized. That, of course, reached a plateau of effectiveness, and then the next breakthrough occurred after I ran into a fellow counterstrainer who is out west, and she's been a patient and a counterstrainer for many years. All her scans are cleared, and she's still in significant pain. And after talking to her, she had undergone over 20 thoracic surgeries. And so I checked her scans briefly at the class, and sure enough, motion testing, everything, she was just full of thoracic scar tissue. So I said, you know what, why don't you come out to the clinic, and I'll spend a couple days working on all this internal scar tissue. But I also wanted to see if I could see, number one, does scar tissue scan anywhere? And is there any way to kind of take this to the next level? Can we really figure out exactly what tissue is in fact scarred? The progression from that ended up being that, yes, in fact, it does have a scan. Yes, in fact, you can identify it. And it actually does have diagnostic tender points, which can allow us to identify what tissue the scar is in and how to treat it. And that's what we're going to be going into next. Okay, so before we talk about the treatment of contracted scar tissue, we're going to first talk a little bit about the physiology of scar tissue in general. There are 4 phases of scar tissue formation. There is the initial inflammatory phase, which lasts about 24 to 48 hours, and during this time, their macrophages come in, there's a debridement of the tissues, and that inflammatory stage, because of the nociception that occurs, causing pain, there is a period of immobilization, which of course is very important. The next phase, called the granulation phase, is characteristic of increased blood supply to the area and vascularity to the area that has been injured or torn. And this, of course, is to meet those metabolic needs of that healing tissue. The third stage being the fibrotic stage, where collagen starts to be laid down. We have an influx of fibroblasts and myofibroblasts, which are, of course, the contractile cells, come in during this stage. And the myofibroblasts, of course, are what can become dysfunctional and cause this contracted scar tissue. And then finally, there's the maturation phase where the collagen matures, it solidifies. Some of the scarring really starts to become more shortening can occur in this stage. And this is the stage where you can start some movement and help to make significant remodeling during this phase. The pathology occurs if during this fibrotic and maturation phase, edema ends up being trapped in the interstitium. So what we end up getting is chemical stimulation of the myofibroblasts, and you get a contracted scar. We don't want to say that we're counterstraining scar tissue, because scar tissue is a normal part of the healing process. We are specifically finding areas of contracted scar tissue due to edema trapped in the interstitium, which stimulates the myofibroblasts. Okay, so when we have a tender point, when we have a scan in this scar tissue paradigm, that is what we found is a contracted scar. So it's important to understand that, so that patients don't think that scar tissue itself is not something that can be in the body. It's a normal process. If we look at the scar in general on the surface, and here you have a picture of a scar. If you look at the proximal part of that scar between the radius and ulna, you can see that it's very flat, there's no edema, and as you go towards the middle of that scar, you can start to see that it's kind of invaginated, it's pulled inward. You can see that probably the interosseous membrane is tight there. You can see some bulging or even swelling on either side of that. And then again, it becomes less edematous and more superficial by the carpal tunnel. And that's very typical with a scar. If you then go in and start to motion test that scar, you'll find areas where it's adhered. And that is where the edema is stimulating the myofibroblasts, okay? So the main concepts in order to do this that you have to understand is, number one, scar tissue is not a random entity in the body. It does occur in specific tissues and in specific subsystems. So we can use the diagnostic value of the fascial counterstrain tender point to see in what tissue the scar exists. So for example, you can have a vascular scar, you can have a neural scar, you can have a ligamentous scar, and the tender points are the same as the tender points you've learned. This paradigm of treating contracted scar tissue is something that anyone can use at any level. So if you've just taken one of these classes, I'm going to teach you how to identify a scar in that ALL, in that anterior longitudinal ligament system. If you've taken all the classes, I want to give you the general way to identify a scar in any system. So that's the first thing, is that there are tender points related to the scar. They're not just random areas of tissue tightness. And that was a real key finding for me, because I was looking at these scar tissue tender points as non-specific, but they are very specific and they have diagnostic points. The other thing to understand is that the scars themselves do not scan normally. Meaning if you have a median nerve scar, it will not scan somatic anterior. However, on the opposite side, we'll talk about in a second, its counterpoint, which is a normal tender point, will scan. So the way we're picking up scar tissue, because we're not going to go into the fact that there are scar scans. I've developed many. It's going to be taught in advanced classes, and it's not appropriate for a webinar. Okay, we're going to use the fact that we found a tender point that doesn't scan, and use its stack to identify what tissue that scar is in. Okay, so if we were to have a median nerve scar, we would go to the area of the somatic nerve and we would motion test it, and it would be negative on the median nerve scar side. But on its opposite side, you might find an ulnar positive standard scan. And the fact that we have a unilateral scan and no partner, no stack, that tells us this is a probable scar tissue because it does not scan. Okay? Now you say, okay, well, what is the tissue? Well, the diagnostic tender point helps us with the scar. So if I went down to my wrist and I checked, I could find my distal median nerve point, which is present on the non-scanning side, and I may have a distal ulnar on the scanning side. So this scanning ulnar point is helping me identify the median nerve. Same thing would be true with anterior longitudinal ligament. One of them, it may scan on one side, ALL, but does not scan here. Then you go into the tender points and you find both. The one that scans, we treat normally, and the scar tissue one, we're going to treat more randomly because it's scar. Okay? The next thing then in number 2, that's what I was talking about, is the fact that we use the biotensegrity stacking concept to identify these guys. All right, so that's very important to understand. A unilateral scan with no partner is a sign of scar tissue on the non-scanning side. Concept 3, the quickest way to then integrate this into your paradigm is to take your existing caseload, use the scans that you already know, and look for a unilateral scan. Okay, if I know ALLs, PLLs, and lymphatics, standard lymphatic row, check your patient for where do I see a one-sided scan, then the opposite side is your scar. The tender point, again, is going to tell you what tissue the scar is in, and then you're going to use not the standard release on the scar tissue side because it's random. So if I had that median nerve point again, our standard release is shortening, of course, down through the carpal tunnel. In the case of scar, it's going to be typically the opposite. Typically, we'll need to go into the direction of ease, which is stretching to release the scar, not shortening. So again, the direction of release for scars is random, but the first thing to try is the exact opposite the normal treatment. So for veins, instead of taking them distally, try taking that scarred vein point proximally. For nerves that we take proximally, try first taking it distally. Okay? Can you then potentially have something scarred in the standard direction? You can, but it's rare. It's usually the opposite direction of the typical release on the scar side. Okay, one more thing about concept 4, scar tissue treating in a random direction of ease. If the dysfunction is an anterior ligament, for example, or a posterior structure like a PLL versus an ALL, it is a front side structure and will typically still need flexion. But what you will see is the side bend and rotations are not typically treated, in the standard direction if it's a scar. So if I had an ALL stack, standard point on the right, non-scanning scar tissue location on the left, I would need on the standard side flexion, rotation toward, side bend toward, classic ALL. The left scar side that does not scan will need flexion, but the side bend and rotation could be completely opposite the normal direction. Sometimes you end up doing the left one right back in the same position as the standard right one to turn it off. Okay, so that's a key thing. Flexion ones don't need extension. They tend to still need flexion. Where you find yourself going completely opposite are in the neurovascular bundle type ones, again, nerves, vessels. Another example might be the median umbilical ligament bladder point, where we would typically glide the abdominal wall inferior. If it was scar, it may need superior with some fine tuning. Now, the next concept is that adhesions typically trap more inflammation than standard tender points. When we're treating a standard tender point, we're into that microvascular system, we're working on those primordial vascular nodes, and they entrap a kind of standard amount of inflammation that takes typically, as you know, up to 45 seconds. But these adhesions can trap a significant greater amount of inflammation in that interstitial space and can need releases that can take up to 3 minutes. You also tend to find yourself having to do unwinding. You'll go in this certain direction, and then you'll find if you just change that direction slightly, it continues to drain. They can really, really take a long time. Because they can trap these adhesions, so much inflammation, they're often in the primary area of complaint. It is very, very common for the majority of the pain in some patients to be from this scar. And they're so easy to miss, and you are currently missing them. So again, you want to go back to your caseload that you're stuck on, use the scans that you know, and look for these non-stacking scans. Positive on the right, not on the left. Where I want to get you thinking is, remember, since they don't scan normally, you are missing them. So if I came in with that carpal tunnel scar on the left, and it sounded like carpal tunnel, median nerve symptoms, you would go up and do your somatic scan, and you'd be like, wow, gosh, I guess it's not carpal tunnel because the somatic scan was negative. What you never did was go to the opposite side and feel that that was positive, okay? Same thing with a sciatica. You say, boy, that sounds like sciatica. You check the scan for posterior somatics on our posterior somatic scan, but you don't find it. So you go, it must not be sciatic nerve pain. But it was a scar, okay? So you're literally looking, in some cases, for the scans on the wrong side to identify them on the scar side. Be aware of that. Some patients are complaining of more pain on the standard tender point side. Some are complaining of the pain on the scar side. Okay, some both. The last concept we need to understand is that some scar locations are very common and some are quite rare. Remember, trauma, surgery, inflammation subsequent to those, and infection are what typically cause scarring. So things that are infected commonly tend to be scarred a lot. Bladders, of course you find it in the lungs. Things that are traumatized easily or have like overuse, rubbing type situations frequently scar. So carpal tunnel, radial tunnel for the radial nerve, those type of locations are very, very common. And when I teach this, and we'll talk about that in a second, when it's taught officially, we'll go through some of the really, really common locations. This is extremely valuable when you get to the highest level, because now you can start to treat the vessels of the brain, the bone scarring, which is vascular, of course, and the periosteum of the brain, and people with traumatic brain injury, Lyme's disease in the head. Very, very valuable for those really tough patients. All right, so next thing I want to do is cut out to a demonstration. I'm going to use my son, Evan, and we'll just run through a demonstration showing you what it would look like if we found a scar and how that treatment would be different from the standard treatment. Okay, so let's see if we can put this into a clinical demonstration. I assessed my son, Evan, here with this paradigm, and what I found, as you can see, are 2 unilateral scans in common systems, and then I'll run through what a treatment would look like. So if we go into the standard nerve somatic scan, and for those of you who have not taken this, it is an inferior scan along the superior surface of the frontal bone, and if I come from the center laterally, right here, it's tight and tender, and that is a positive for the area around the brachial plexus. As I go more lateral, it's okay, so it's positive here, but I go to the same region on the opposite side, and the scan is apparently negative. Positive, negative. So this is a potential scar on the left in the area of the brachial plexus, compensated for in a biotensegrity stack by a standard on the right. So we'll jump up into this brachial plexus area. And again, if you haven't taken this class, this is just a demonstration of the concept. I'll do one in the vein. You're going to do this in the systems that you know. So I'll come over here, and there's a very cord-like tightness on the anterior part of the brachial plexus. Do you feel that, Evan?
Yeah.
Yes, he does. And that one was standard. So we shorten that guy. We'll come in here to the neurovascular bundle posterior to the biceps, glide cephalad, and we'll get that to soften. Right there, starts to drop out. And this does not matter what order we treat. If we treat the standard one first or the scar tissue first, it really doesn't matter. It's important that we identify the stack and the scar tissue side and do them in the same session. Okay, very good. Finishing that up. And drop back down. Come back to the scan, and there's our standard brachial plexus is good. This is the brachial plexus posterior right here. Feel that one there, F? Okay.
Yeah.
Now if I do a little adversarial tension test like radial nerve and come up there, you feel that, Evan?
Mm-hmm.
It's really tight. And sit up tall there for a second. And this is really binding, but this whole brachial plexus posterior part on the posterior somatic doesn't scan. The parts of it that tend to even scan in the front don't scan. So posterior somatic, anterior somatic, it's saying it doesn't exist, but we just found the tender point. So if I were to then go on that guy and go to the posterior part of the plexus and release it, as soon as I glide up, I'm actually hitting resistance, okay? There's a lot of tightness. Do you feel sensitivity there, Ev? So I'm up here in his neurovascular bundle, and it's very rigid here. It's fighting me. I go more proximal, still feels like resistance. It doesn't like the standard treatment. So coming along that bundle, I'm going to go to where I feel the resistance in the standard direction and go the opposite direction. I'm going to glide it down towards the hand. So gliding inferior, right there, instantly that dropped out, and I'm doing a scar tissue treatment of the posterior part of the brachial plexus down as it heads near the elbow. Okay, we can even feel along that radial nerve area, but it was really this more posterior part of that neurovascular bundle right in here where the adhesion is. Okay, and I can go in locally and feel that soften as well. This is still releasing. Again, it's taking a lot longer than a typical release. That band is gone, and it finishes up. Okay, come back down. Now I can glide proximally. Do you feel any resistance there now? Yeah, no resistance. Okay, the scan on both sides is now going to be equal. This was negative, and this is now cleared, and we fixed the scar. So we'll come back, check our radial scar, glide, and now it's here. Feel that? Okay. Yeah. So that freed up a scar in the posterior aspect of the brachial fascia, affecting the posterior aspect of the cord. Okay. One more example. I found a vein tightness. So I came here into this thoracic region, and I pull straight down, and there's a positive venous and lymphatic scan in the thoracic area on the right. On the left side, nothing. Okay? Right positive, left nothing. So I'm going to look at what vein points we have on the right side to then get an idea as to where my scar is in the venous pathway on the left. Again, off camera, I quickly examined him, and what I found was a subclavian point, which is in the middle of the infraspinatus. Swing around here a little bit. So right here in the middle of the infraspinatus, there's a big trigger point, and that did scan. So that subclavian vein treatment is going to be done normally. And what we found on the other side was along this lateral aspect of the superior infraspinous fossa, and that is the brachiocephalic or innominate vein tender point. And this one did not scan. Okay, so innominate scar and subclavian normal. So we'll go into the subclavian, do the standard release for vein, which is distal. Drag that out. You can leave your head neutral there. Okay, and release that out. Get a quick pulsation, nice softening. But when I go to do the brachiocephalic stretch, because it's a vein, what we're going to find is that we feel resistance because it's going to need some other direction. So we're going to find the direction of ease. All right, very good. On the subclavian, come back, and that scan is now negative. Again, apparently there was no stack, but we know it does exist. It's scar. So I'll come in here, feel this big trigger point there. Evan can tell you that's nice and snappy. A standard release would be here, and we'll try that. Could work. No, I feel resistance instantly here. This is still snappy. So I'm going to check this for a direction of ease. Doesn't want to go on the standard direction, okay, of decompression. Go into the direction of shortening. It's easier. Inferior is easy, okay. Down and to the right is easy. Cephalad is tight. So this is direction of tightness. This is direction of ease. So we're going to pull down, and I can swing around for the camera. and I'm going to go in the direction of ease this way, which is kind of like an aortic arch or a left brachiocephalic trunk artery treatment. And in this direction, right there, we'll start to get a good strong pulse, flattening out. And we'll treat the vein scar. Again, ended up just about opposite the typical release. And then I'll do one example of like an ALL, anterior longitudinal ligament, what it would look like, although I don't think Evan scanned positive for that. And that finished out. So what we saw were two neurovascular type scars on the left side from some old trauma. Evan played a lot of sports. And with a non-stacking positive scan in both the somatic nerve and vein systems. Okay? Again, there are scans for scar. We're not going to get into that. All you need to do is find a unilateral scan, find its counterpoint, treat it in direction of ease. Okay? Last example, ALL. Checking him for unilateral scans, and I really don't have one, but let's say we did find one in the upper thoracic, and we had a positive scan on the right, let's say, and no scan on the left. I would go to the rib tubercles, find which one existed. If we found an ALL point on that lateral aspect of the tubercle at T8 on the right, we would treat it in the standard, knock it out, come back, go to the T7 or T9 stack, and let's say we found one at 9, try the standard, but what we would feel is it tightens right up typically because it didn't scan, and then say, okay, it likes a little bit of flexion, but it doesn't like side bend toward, rotate toward. So let's try side bend away, let's try rotate away, and find what it really needs. Okay, many times you may end up treating a left ALL in a position that looks similar to the right. Okay, so those are some basic concepts. Again, start working on that. Take your existing caseload, go through the scans you know, look again at them with a scar tissue paradigm. Does this person have a unilateral scan, and are they having residual pain on the side that doesn't scan, indicating a scar? And just that shift in paradigm and knowing you're going to treat it in a random direction is going to make the difference for many of your toughest cases. Okay, then just to recap, scar tissue has scans, but they're not the standard scans. So what you're looking for is the biotensegrity stack in the same system to identify where that scar tissue adhesion is. Okay, they can occur in vascular tissue, arterial system, lymphatic system, periosteum, nerve, you name it. But we're using the power of the diagnostic tender point to see where that tissue is. So in the case of what we just demonstrated on Evan, I figured out that the adhesion was in that neurovascular bundle of the brachial fascia, and I was able to feel where that adhesion was by going along and feeling for the restriction. And again, as is typical, since scar tissue is longitudinal in a neurovascular world, the treatment was in the wrong direction. I had to stretch the nerve, not shorten the nerve, okay? You can use this concept locally as well. So if you have a post-operative knee, perfect case where there could be scar tissue, you had a surgery, inflammation, possibly infection, you can find this concept very effective just on a local basis. So if you're in the back of that knee and you feel that there are multiple lymphatic tender points that are positive, like the lateral sural veins, medial sural veins, popliteal vein, etc. They have a Baker's cyst, a lot of edema, and then you go to do one of those releases, and as soon as you glide it distally in the vein direction, it suddenly tightens. And you're like, wait a minute, why did that tighten? I'll say, this could be an adhesion. So you go up, quickly see, does it scan? And if that remaining tender point, that one that won't turn off, doesn't scan, then it is a scar, and you just go in the wrong direction or a random direction. Technically, anytime you find a point that seems to tighten right as you go to release it, it could be a scar, and you can try the opposite direction, knowing that its partner on the other side is going to scan and treat typically. All right, so again, you can use it locally. This concept that we're giving you today, in the big scheme of things, essentially doubles the amount of identifiable and treatable tender points in the body. Why? Because every single tender point can also have a scar. And it's hard to impart how important that is in a clinical setting, but it will explain a whole lot of the patients that are not responding that are currently on your caseload. You will find scar tissue dysfunction is present in about 70% at least of chronic pain patients as one of the major players in their pain. I'm finding myself now when a patient comes back that I've already seen and they're saying, you know, I've still got this one thing, I'm finding almost every single case it is a scar problem, and that's why I wasn't able to identify it. So just knowing that this exists, just knowing that these things break the rules, okay? They don't scan, and you treat them in the wrong direction. They literally break the rules. It opens up your mind, changes your paradigm, and you'll take a new look at that patient, and you're like, ah, there it is. It's a scar. And you know, I was beating my head. I couldn't figure out why you still had edema when nothing was scanning positive. And then the last thing I want to say, you're going to have a lot of success with what this webinar is giving you, but you're just touching the surface. This is going to be formally taught in the Central Sensitization Class 2 and 3. We're going to go over all the common locations and the scans for scar tissue in Classes 2 and 3. Class 2 will go through the standard ones for artery and vein and all the ones you already know. Class 3 will be going into scar scans for brain vessels and periosteal structures, things that we don't treat to the final central sensitization series. Okay? So again, lots of additional power without having to learn any new points. It does take a high level of clinical skill because I can't map out the direction of ease for you. You have to be able to feel that, but it's really much easier than you think, and it's really going to make a major difference in almost all of your toughest patients, particularly those who've had infections, surgeries, and traumas. Although there are many cases where you find scar and you just can't figure out in that person's history where it came from. So don't let that dissuade you from looking at it. Hopefully, this COVID thing will be over soon, and we'll be able to get back with you guys and do some more formal training. The fact that we can't have large groups for a while is obviously putting things on hold, but this will give you something that you can work on right away. Again, get your hands on people while things are slow at your clinic and try and at least get a jump on this scar tissue paradigm. It's going to make a big difference for you guys. Take care.